We're honored to have Dr. MILLY SHAKOOR, who's the professor of National Eye Institute of Ophthalmology in Bangladesh, as the keynote lecture of the session, and we are extremely honored to have you here, Dr. MILLY. And Dr. MILLY is trained with Dr. Santosh Hunavar in ocular oncology, and she does excellent work in ocular oncology in Bangladesh. And over to you, and welcome.
Thank you, Dr. Fairuz. Good afternoon, dear colleagues and my mentor, Professor Dr. Santosh Hunavar sir, and everyone here. Greetings from Bangladesh, and I'd like to express my thanks to AIOC for inviting me to deliver keynote speech in this session. I'm working in National Institute of Ophthalmology, and also as a consultant, I work in Bangladesh Eye Hospital, Uttara. So I'll be sharing how I have started to establish a center on ocular oncology in Bangladesh from zero to a established center now. So ocular oncology or eye cancer is an emerging subspecialty dealing with the study and treatment of tumors that occur in and around the eye. We all know that. But in 2000 till 2013, there was no structured oncology services in Bangladesh. So people, ophthalmologists and oculoplastic surgeons were dealing with the tumors, but no specialized center. In 2014, I had the chance to do my fellowship in ocular oncology and oculoplasty at Center for Sight under Dr. Santosh Hunavar sir, and it was the gateway to this specialization. And it was not recognized as a separate specialty till 2014. And in 2015, we have repeated meetings, and we try to make understand the authority to accept it as a unit at National Institute of Ophthalmology, and they identified as ocular oncology unit at my institute. So we started doing ocular oncology, and there are I will quickly go through some of the cases, and just to let you know that what we started doing at that time. So it was some lead growth, and we did multiple modalities of treatment or surgery, and then finally this outcome was got. It was a basal cell carcinoma, and it was also a lead growth. And there are so many, but I have taken few cases to show you that what we are doing after that, after this training. That kissing nevus we did, and then OSSN, first only emanating membrane graft, and then with mitomycin C, and finally we regularly use interferon alpha 2B now. So step by step we are moving to the global standard treatment. But we don't have plaque brachytherapy, so I'll be coming to that point. And cavernous hemangioma, we did just orbitotomy, and this optic nerve glioma, non-Hodgkin's lymphoma. Lymphangioma we treat with injection bleomycin, and with excellent result. Some of the cases come to us, extensive cases, we have to do exenteration to those patients. So we just treat, but we don't let this patient go, because we have learned to treat cases comprehensively. So we established a network and collaboration with National Institute of Cancer Research Hospital and National Neuroscience, National ENT Institute. So our cases are dealt with comprehensively in these 4 hospitals, and if needed in other hospitals too. And we have experienced histopathologists so all our cases are dealt with a single histopathologist, very experienced one, and if needed we take second opinion from other histopathologists and treat them. But challenge was to treat retinoblastoma, because retinoblastoma patients, there are multimodality treatment, and this patient presented with indifferent this kind of presentation we took computer CT scan we did, and B scan, ultrasonography. All the patients we do this for documentation, and also it helps us for counseling also. And we follow international classification of retinoblastoma, Shields classification in our center, and international staging system for retinoblastoma. But till 2014, we had nothing. And we were just getting referral cases because people knew that someone came from Dr. Santosh Sonavar sir, trained from Dr. Santosh Sonavar, and she knows retinoblastoma. So patients were coming, but we had nothing to give them. We just did EUA, and we grouped the patients, and we referred the cases to Pediatric Oncology Department of National Cancer Institute for chemotherapy. And some of the cases, which group E cases, we did enucleation with orbital implant when needed. But the challenge was follow-up. Those patients were not coming up from that center. So we used to give prosthesis from day one. All the patients got prosthesis. So referred patients were not coming back for follow-up. That was a crucial. And those who were reporting had incomplete chemotherapy, like they took one chemotherapy and they didn't go for follow-up, then again irregularly they took another cycle. So we decided to start chemotherapy at NIO. At that time, in 2015, this is my first case who got chemotherapy, and at that time we had to give chemotherapy. The patient had to buy the chemo, and we used to give the chemo here. So it was a little bit expensive for the patients. So intravenous chemotherapy at National Institute of Ophthalmology. And other modalities of chemotherapy also we started, periocular chemotherapy and intravitreal chemotherapy at that time. But it was very expensive for the patients. These are the cases here. You can see that group D RB is cured with intravenous chemotherapy and intravitreal topotecan. And this is group BRB, regression with intravenous chemotherapy. This is also regression, group C RB treated with intravenous chemo. Then we thought that we have to have a comprehensive center for retinoblastoma in Bangladesh. So at that time we had these treatment options like cryotherapy, laser photocoagulation, and enucleation we are doing, and intravenous chemotherapy. So we wanted to understand our authority to make it a center with all the treatments available. But it was not their priority. Their priority was cataract, and cataract. They wanted to buy the big phaco machines, microscope, and everything needed for a phaco and vitreoretina, but not for retinoblastoma. So the negotiation was very crucial, and I didn't give up. I was counseling them and telling them, we need it, that's all. And in 2017, they recognized as a separate department for retinoblastoma, that retinoblastoma unit. And we have now dedicated OT day and chemo day, dedicated inpatient bed for RB. We can admit the patients when those patients who comes from different rural places, and dropout reduced to minimum. So 2017 was a very important and crucial year for us. And 2019, we procured transpupillary thermotherapy, and also one thing happened in National Institute of Ophthalmology. Governments gave supply of vincristine, etoposide, carboplatin, and topotecan. So we don't have to wait for chemotherapy anymore. So it was a new era started in the treatment of RB in Bangladesh. So this is TTT, my first case. And after TTT, the results became very improved result, and tumors regressed, and all good news started coming. So we also gave intravitreal topotecan when needed. So it was a dream, because I dreamed, because my mother died from cancer, and as an ophthalmologist, I can also be a ocular oncologist. So that was the thought for me to become a oncologist. But that dream, we have to have was continuing, what I can do more. We needed RADCAM, we want plaque brachytherapy, we wanted to start intraarterial chemotherapy and want to do research in genetics of our retinoblastoma in Bangladesh. But dream is dream. Different modalities of chemotherapy had, you can see in the, till 2021. We are giving everything, but intraarterial chemotherapy was not possible at that time. Then, 2021 January, it was 25th January 2021, we gave our first intraarterial chemo, and, but unfortunately, they didn't follow up and the result was not good. But then we gave another 2, and they are doing well. So, step by step, at National Institute of Ophthalmology, Ocular Oncology and Retinoblastoma Department was established. Still, our dream is we want to have RADCAM. But how we are doing that without RADCAM? Because we take montage photograph of the fundus, and we compare those every month. In that way, we are just that expensive RADCAM we don't have. Plaque brachytherapy, we are on the way to procure it. Hopefully we'll get, because now I thank Dr. Sundar Srinivas sir, because due to his good intention, now we have made in India plaque brachytherapy, and hopefully we'll get it soon. And we are planning some research in genetics of RB in Bangladesh. We are talking with a center in USA, so maybe very soon we'll have that research started. And we also have networking with blind schools. So those who have bilateral RB or vision, poor vision, they are enrolled in these schools, and so they will be in the mainstream of population. So in conclusion, nothing is impossible. Says you have to have a dream, and need to work step by step to fulfill that dream. And you have to have a mentor also. And I have a mentor who helps me in every step of my treating this retinoblastoma or oncology patients. So I'm very thankful to my mentor. And one thing for the young ophthalmologists, so dream big, but start it small, and step by step you can achieve what you dream. In Bangladesh, we can manage RB more confidently, and we can say that, inshallah, we'll move forward. And this was my first chemo patient. She's surviving, and she's very, now 8 years old, going to school, and one eye, she has good vision. And this, my team, without a team, we can't do our work. And this is me with my mentor, and in this occasion, I like to thank my mentor for his continuous support, for his inspiration. Now, I can do, and I can establish this center at National Institute of Ophthalmology and can serve so many people. Thank you, sir. And also, I'm doing it in National Bangladesh Eye Hospital also, establishing another center now on the way. So, thank you, sir.
Thank you, Millie. Thank you for dreaming big and working